Welcome to our first podcast on the respiratory system. In this unit, we are going to look at the anatomy of the respiratory system from our oral cavity and nasal cavity, our trachea, our lungs, and then we're going to move into the processes that cause ventilation, moving air in and out of our lungs, and then we'll also look at gas exchange, the exchange of oxygen and carbon dioxide between the air in our lungs and the blood, or between the gases in our blood and our tissues. So first, a few definitions we need to throw out. When we talk about respiration, it can mean a number of things to a number of people. So respiration could, in fact, actually be defined as ventilation. The mechanical process involved in breathing, the expansion and the contraction of the lungs, thereby pumping in air in and out of the lungs. Respiration can also mean gas exchange. Gas exchange is done entirely by diffusion. No energy is expended other than that it takes to move the air in and out of the body. But we can break this gas exchange down into two separate categories. Now, this is a little bit tricky, so hang in there with me. When we look at the exchange of gases that occur between the air in the lungs and the blood that's in the capillaries, because those are the smallest vessels that allow exchange, that is external respiration. It's the exchange of gases that are in the external air in your bloodstream. Now, granted, they're inside the lungs, so be very, very careful. You're going to want to call this internal respiration because it's happening in the lungs, but it's actually external because of the external air that's brought into the lungs. Now, internal respiration, by definition, is going to be the exchange of gases between the blood and your body tissues. That's the level at which we have internal respiration, that deeper level in your tissues. Think of it maybe in the tissues of your big toe. But in all the tissues of your body, they undergo internal respiration. Now, we could apply the term respiration to oxygen utilization being at the end of our electron transport chain. We have oxidative phosphorylation occurring, the production of ATP. Well, that's cellular respiration or aerobic respiration, as we might refer to it as. So here we see ventilation, the process of inhalation, moving air into the lungs, and exhalation, moving air out of the lungs. And then we see external respiration in the upper left, internal respiration here on the right, and we can see the movement of our gases into or out of the blood. And then cellular respiration, just represented here by a portion of the Krebs cycle. Now, let's review the anatomy, a little bit of the body that's going to make respiration, ventilation possible. So when we look at where our lungs reside, this is going to be in our thoracic cavity. Now, not only lungs, we're going to have the heart, the thymus, the trachea is moving down from our oral cavity to the thoracic cavity. And this is going to be separated from the abdominal cavity by the diaphragm. That's the partition that separates the thoracic and abdominal cavities. Now, our organs and the lining of our body cavities are covered by a very thin membrane, a single layer thick. It's made up of mesothelial cells, and this is called a peritoneum. Well, in the lungs, your parietal peritoneum is more appropriately called the parietal pleura because we're in the pleural cavity, and pleura deals with the lungs. So the lining of our thoracic wall is going to be our parietal pleura. Whereas we also have this very thin membrane covering our organs, and in this case the lungs, and this is the visceral pleura. Now, this is going to create somewhat of a low friction surface. It's also going to prevent adhesion of our outer portion of our lungs with our body wall. But there's not, in fact, going to be a space there. The lungs are always going to be pushed up against the body wall. And so our visceral pleura and parietal pleura are always going to be in contact with each other unless you accidentally leak some space in, which could happen with a wound, which would lead to a pneumothorax. That's air getting into this space between the parietal and the visceral pleura. And that space we refer to as the intrapleural space. So there's the potential to have a space there, but in fact, in normal conditions, there is no space actually visible. So we refer to it as a potential space. Here we can see in a cross section, right lung, left lung. This would be the area where we would see the heart. And so what we have in the purple, that is going to be the visceral pleura, closely adhered to the lobe of the lung itself. And then, even though I don't like exactly how this blue line is drawn, you can see it is with the body wall, and that will be our parietal pleura. We can see the same thing over here in a coronal section. Again, here to the lungs, that would be the location of our visceral pleura. And then the outer line against the body wall, that is our visceral pleura. So that's our thoracic cavity, and our lungs reside in the thoracic cavity, and this is where we're going to undergo external respiration, but we have to get the air from the outside environment to the lungs. And so as we look at the duct work, if you will, the passageways of getting air from the outside to the inside, the first part of our respiratory system is referred to as the conducting zone. It's moving air. It's going to clean particles out of the air with mucus-producing cells and ciliated cells. It's going to humidify the air. It's going to warm the air. But the principal function is to transport air down to the level where we will undergo external respiration. So the first part of our conducting pathway is going to be the extrapulmonary segment. Extrapulmonary simply meaning it's outside the lungs. And so we include our nasal and oral cavities, the first place we're bringing air into the body. The back of our throat is this union of nasal and oral cavities we call the pharynx. The larynx, or the region of the voice box, this is actually going to be a divergent area where air is shunted into the trachea, and food and water can be diverted into the esophagus, which is going to be dorsal to the trachea. And the trachea runs down through our thoracic cavity, through and it branches into a right and a left branch, and we call these the primary bronchi. So the single trachea will give rise to two primary bronchi. Now, each one of these bronchi, one on the right, one on the left, will dive into the lung tissue itself. So now we become intrapulmonary. So each primary bronchus is going to split into secondary bronchi, and you'll have 10 on each lung, 10 on the right, 10 on the left. These will branch into tertiary bronchi. And then you see the dashed, the little dots there. Basically, we have 17 orders of more branching to go. And then we get down to some of the smallest tubes or ducts that we have in our respiratory system called bronchioles. We're not going to worry about their diameter. We cover that when we get to our histology course. But then we finally get to these terminal bronchioles. Now, they're terminal in the sense that they are the last stage of our conducting pathway, but they're not terminal in the air does not dead end here. The air is going to continue, but then we're going to move into that portion of the respiratory ductwork system where gas exchange can occur, and we'll give that a different name. So terminal bronchioles are simply the last portion of the conducting zone of our respiratory pathway. We don't see the oral and nasal cavity. We sort of know what those look like, but here we are at the larynx. Air is going to move into the trachea. Here we have a left and right bronchus. Then we can see our secondary bronchi branching. They call this the bronchial tree, that basically all those orders of branching. And as we branch with more and more branches, the diameter gets smaller and smaller and smaller until, for the conducting zone again, our terminal bronchioles. And you have about 60,000 terminal bronchioles that make up your respiratory system. Now, the remainder of our pathway is called the respiratory zone. We're continuing to transport air. We are beginning to undergo gas exchange. And remember, in the lungs, that is external respiration. But we're also going to have some cells that produce a very important substance called surfactant. And we're going to see that it breaks the surface tensional forces of water and helps keep the airways open so gas exchange can effectively occur. So we go from about 60,000 terminal bronchioles. Now we move into 500,000 respiratory bronchioles. Now, this is mostly a little tunnel that has some areas that gas exchange can occur. Then from these respiratory bronchioles, we end up in essentially passageways that are called alveolar ducts. There's really no structure to these alveolar ducts. They're simply made up of these long stretches of space between the little bubbles where most of the gas exchange is going to occur. They're called alveoli. And when you line these alveoli up in two rows, the space between is simply the alveolar duct. If the alveoli weren't there, there would be no alveolar duct. Likewise, when you get to the end of these ducts, these alveoli cluster together in what looks like a cluster of grapes, and that's an alveolar sac. The inside has an antrum, in which is just this common area that can go to either one of the alveoli that make up the alveolar sac, and there are about 8 million alveolar sacs in your respiratory system. But then when we count up all the alveoli, these little tiny bubbles, we have over 300 million alveoli present in the lungs. Now we can see on the left as we're coming down our tree, we've got our conducting zone. There's our terminal bronchiole, the last part of the conducting zone. Respiratory bronchioles are next, and we have, see, just a couple of these little bubbles, alveoli, on them. The alveolar duct, we're not illustrating, but it's going to be in the midst of this alveolar sac. It's coming right down the middle before we get to this. And then each one of these is the alveoli in which gas exchange is going to occur. Now, on this side, this is an interesting picture because it's what it's representing are bronchopulmonary segments. There are 10 segments in each lung, 10 on the right, 10 on the left. The secondary bronchiole is serving each one of those. Each of the bronchopulmonary segments are separate from the other divisions of the lung. So if you happen to have an injury and damage one area of the lung, the entire lung integrity is not going to collapse. That's not what we call a collapsed lung. Damaging one of these segments will only damage one of the segments, but you have 19 more present in the respiratory system. Now let's talk a little more about these alveoli. These are the locations where external respiration occurs. Now we said that capillaries are the smallest vessels that can allow exchange. They're only one very thin cell layer thick. Well, the alveoli are the same, this one very thin cell layer thick. They're only about up to maybe half a micron in diameter, and recall a red blood cell is going to be 8 microns in diameter. So they're small compared to a red blood cell, but there are a lot of them. And when you take those 300 million alveoli times that diameter, you basically are going to come up with 760 square feet of surface area for gas exchange. Now that's increasing the surface area to allow diffusion to effectively occur. Well, as I mentioned, the capillary endothelial cell and the cell that lines the alveoli, that's going to create the blood-air barrier. Now in the capillary, we call them endothelial cells. In the alveoli of the lungs, those thin cells we call type 1 pneumocytes. They're going to be flattened, look like fried eggs, just like the capillary endothelial cells, and so there's very little distance for the gases to diffuse, oxygen and carbon dioxide. And remember, we can enhance diffusion by shortening the distance between the two concentration gradients, and that's how we do that here. Now, type 1 pneumocytes, these are big fat cells that we're going to find in the alveoli and in our alveolar ducts. These are the cells that produce surfactant, and we'll spend a lot more time talking about surfactant. But surfactant is a lipid, almost like a detergent, that breaks the surface tensional forces of water to help keep these little alveoli open and functioning. Now, here's an artist diagram of what we might see within alveoli and a capillary. Again, an artistry, this, not a biologist, because we know the diameter of an alveoli that we see here at the top is about half a micron, and the average diameter of a red blood cell is about 8. So the scale of this is totally messed up. But they're trying to illustrate the flattened endothelial cells, the flattened type 1 pneumocytes, and that's going to be our short blood-air barrier. Here they're showing the giant type 2 pneumocyte and the surfactant, how it's coating the surface. But we're only going to have about that 0.3 micron distance for oxygen and gases and carbon dioxide to diffuse across. This just shows you some of the players, and again, not a very good job on the scale. Now let's consider the process of ventilation. Now what we're going to see is ventilation is accomplished by changing the thoracic volume. We're going to increase the volume to cause air to move into our lungs, and we're going to decrease the volume to force air out of the lungs. So we're going to see that really when we talk about moving air, it's all going to be a measure of the pressure differences between the inside of the lung and the outside, or the environment. And it's also going to be a function of the frictional resistance of the flow, meaning the dilated versus the constricted nature of our airway. The smaller those airways, the greater the resistance, the less flow. Hence, that's why we talked in our autonomic nervous system about those different responses and the dilation of our airways during a sympathetic response. So, as the thoracic cavity expands, we're going to create a slightly lower pressure in our intrapleural space. And this is going to be between the visceral and the parietal pleural, recall. Now, this lower pressure, this is going to cause the lungs to push against that. So this is the reasoning behind the fact that our visceral pleura, or the wall, the outer wall of the lung, is going to continuously be pressed against the thoracic cavity. So wherever the thoracic cavity goes, so go the lungs. If you increase the space of the thoracic cavity because of this negative pressure in our intrapleural space, you're also going to increase the volume of the lungs. They mimic and follow that thoracic cavity. So in our illustration, atmospheric pressure is going to be 760 millimeters of mercury. That's 1 atmosphere of pressure. We can see at rest, we're not inhaling, we're not exhaling, we're somewhat in the middle. But our intrapulmonary pressure, inside the lung pressure, is 1 atmosphere of pressure. So no air is moving in or out. The net movement is 0. But that pressure between our pleura, our intrapleural pressure, you can see it's slightly lower, so the lungs are continually pushed against the thoracic wall. When we inhale, we can see that our pressure in our lungs, because we're increasing the volume, that's going to be slightly lower, 756 millimeters of mercury. With a lower pressure difference, now we've got a gradient. Air is going to rush in to our lungs from the outside, following the low pressure. But still, even when we increase that cavity, our intrapleural pressure is still going to be lower. So our lungs are still pressed against the body wall. Here we're with expiration. As our volume decreases, now we're slightly above at 763 millimeters of mercury in our intrapulmonary pressure, higher than we see in atmospheric, so air is pushed out. Yet, once again, our intrapleural pressure is lower, and even when we exhale, our lungs are still pressed against the body wall. Now, when we look at the difference between our intrapulmonary, inside the lungs, and intrapleural, just that space outside, that is called the transpulmonary pressure. And that difference, because of that low or more negative intrapleural space pressure, it's always going to be positive, and that's why the lungs are continually pressed against the body wall. Now, we've talked about volume, and this is why volume is important. Because when you look at that space in the thoracic cavity, unless you have a wound or unless you have damage to the lining of your lungs, you're not going to increase or decrease the air that's inside the thoracic cavity in that intrapleural space. Now, our lungs, however, that's different. We can bring more air in and have air go out. But Boyle's law is going to dictate pressure differences. And what Boyle's law says is that the pressure of a gas is inversely proportional to its volume. Basically, what that means is the greater the volume, the lower the pressure. The lower the volume, the higher the pressure. And you can put it into work here in this little diagram. What we can see as our volume decreases. We're not letting the air move anywhere. We're keeping that certain amount of air confined. But as our volume decreases, our pressure increases. And likewise, as we increase the volume, our pressure decreases. That's the inverse relationship we see between volume and pressure. And that's how we cause air to move in or out of the lungs. Now, if we're moving our thoracic cavity, our lungs are expanding and contracting. Well, our lungs are going to they're going to have to stretch, which is called compliance. They're going to have to be elastic because they're going to have to rebound. And then we've got to deal with the surface tension, and that is the function of surfactant. Now, that's one of the more critical aspects, especially very early in our life, is dealing with those surface tensional forces created by water. Our bodies are mostly water. And when we think about those small bubbles, those little diameter alveoli, the surface tensional forces are water trying to round up into these little balls. And if you've ever watched the astronauts play with water on a space shuttle, water wants to be a sphere. Water's continually pulling against other water molecules to create a sphere. Well, here on Earth, we deal with gravity. But those forces are happening in 3 dimensions. So if that happened on the inside of an alveolus, it would be strong enough to collapse the alveolus, to close it off. You would never get air to that point, and therefore you would never have any external respiration. So we have to break these forces, these van der Waals forces and these hydrogen bond forces between the polar molecules of water. Well, the law of Laplace sort of puts this into perspective. And basically, the law of Laplace says that when you look at alveolar pressure, it's directly proportional to the surface tension and inversely proportional to the radius of the alveolus. Basically, what this says, as the radius of that alveolus decreases, the pressure needed to keep it open increases. Well, we're already at half of a micron, and so we're pretty small. So we're going to need quite a bit of pressure to keep that alveolus open, resisting the surface tensional forces of water. Well, thankfully, we have surfactant. And again, surfactant is a phospholipid mixture produced by the type 2 pneumocytes, primarily phosphatidylcholine, phosphatidylglycerol. But what these hydrophobic chained molecules do, remember we got the charge group, we have the hydrophobic tails, they interact with water and they essentially create shells around water molecules and then have the hydrophobic tails pointing outside. It's almost the opposite of having albumin in your plasma coating insoluble molecules to make them soluble. In this case, we're coating water molecules to keep the water molecules from interacting with other water molecules. They simply get in the way. And how that's going to help, here's the law of Laplace. The pressure needed to keep an alveolus open is 2 times your surface tensional forces divided by the radius. So here we have an alveolus radius 1. Here we have an alveolus that's twice as big. Now, in this big alveolus, the pressure needed simply equals the surface tensional forces. But when you divide that in half, now the pressure is twice the surface tensional forces. So the smaller alveoli have a harder time staying open. Well, as surfactant is produced and secreted into those alveoli, it coats the alveoli, it coats the alveolar ducts. What we're going to see is those amphipathic molecules, there's the charged head, there's the hydrophobic tails, they are going to intersperse themselves between the water molecules and essentially negate the surface tensional forces. Let's look back, law of Laplace, really quickly. If we make our surface tensional forces 0 because of our surfactant, then what's the pressure needed to keep an alveolus open of any radius? What is 2 times 0? It's 0. 0 divided by anything is 0. So the pressure needed to keep any alveolus open is 0. And that is the real nice advantage of having surfactant. You can see without it, the alveoli is closed. With surfactant, it is extremely easy just by the air that's left over in your lungs. It's that easy to keep the alveoli opened. Now, as I mentioned, this is going to particularly be a challenge for newborn babies and premature babies, that maybe those cells haven't begun to produce a significant amount of surfactant yet. And in that case, those babies are going to suffer from what is known as respiratory distress syndrome, or RDS. So if infants are less than 28 weeks of gestation from fertilization to this point, 28 weeks, they have a 60% chance of expressing some form of respiratory distress syndrome. Prior to 28 weeks, you're not necessarily going to have the architecture of alveoli even present for gas exchange to occur. So survival before 28 weeks is very iffy. It's very dangerous indeed. Now, what they can do in NICU units is they can get a respiratory therapist to come in and administer exogenous surfactant to the baby. And in that case, they're injecting the surfactant directly into the airway, and that hopefully will facilitate the opening of the alveoli to allow external respiration to occur until the infant can produce enough of its own surfactant to survive on its own. That's sort of very extreme cases of premature babies to offset the respiratory distress. Now, for adults, we talk about acute respiratory distress, and in many instances, this is going to be a response in adults because of inflammation. Now, a lot of viruses will cause this kind of inflammation and fluid building up in the lungs because of the vasodilators, the increasing vascular permeability. It's just a normal inflammatory response, but when it happens on a large scale in the lungs, this can be a fatal condition. Because if you're not getting air into your bloodstream, if no external respiration or not much external respiration is occurring, you're going to suffer from hypoxemia, low blood content of oxygen. Now, first of all, your heart's not going to function with that, and many other organs are going to begin to fail. And it is a very dangerous place to be. Here's an illustration, H5N1. When it infects the cells of our respiratory lining, because this is an airborne virus, again, you're going to set up those pro-inflammatory cytokines from the cells that are infected. Our other immune system cells, they're going to be producing the inflammatory lymphokines, cytokines. Here we've got T cells. They're going to be producing. So you see how this is the perfect storm that are going to be producing all these inflammatory molecules that, again, we're going to lead to tissue destruction. We're going to lead to death of the tissue by necrosis, leukocytes coming in, inflammatory response, dilate blood vessels to get them in there, and it's going to just make this worse and worse and worse until practically you drown in your own tissue fluids. That is an extreme case, but that is a problem with what we see with the immune system working overtime to try to eliminate these viral particles from our respiratory tract. And the danger then in slum influenza viruses that can be extremely virulent and do quite a bit of damage to populations.